Good morning, everyone. We'll begin the Quality Payment Program Year 2 Reporting Made Easy. At this time, my name is Alberta Noonan. I'm from the New England QIN-QIO, and I will be your moderator for today's webinar. The Quality Innovative Network Quality Improvement Organization works with healthcare providers, stakeholders, communities across New England on a data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation. I will provide you with instructions on how you can ask a question over the phone or pose a question in the chat box. Please make sure to send your questions to all attendees. At this time, we have this disclaimer. This information that was prepared as a service to the public and is not intended to grant rights or impose obligations. This information may contain references or links to statutes, regulations, and other policy materials. The information provided is only intended to be a general summary. It is not intended to take place of either the written law or regulations. We encourage readers to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. At this time, I'm going to turn the webinar over to Tashira and Rajika. One moment.
Hi everyone, welcome to today's webinar, Quality Payment Program Year 2, Reporting Made Easy. My name is Radhika Sabnis. I am a Program Coordinator with Health-Centric Advisors, and I work on the Quality Payment Program eligible clinicians. And today presenting with me is Tushara James, who is also a Program Coordinator with Health-Centric Advisors, and she works on the Quality Payment Program as well. So today's agenda is we'll be going through the QPP Year 2 overview, and then we'll be talking about data submission for performance year 2017. I'll be going through preparing for performance year 2018, in which I'll be covering how you can avoid negative payment penalty for the performance year 2018, steps you could take to prepare for reporting, and I'll be focusing on grouping measures to report. We'll be displaying a few resources that will be available to you, and then eventually opening it up for questions later on, and our contact information will be displayed for you to get in touch with us at a later point if you need to. Here are a few acronyms that we'll be going through frequently during this presentation. For example, CMS is Center of Medicare and Medicaid Services. MIPS is Merit-Based Incentive Payment Program. MACRA is Medicare Access and Chip Reauthorization Act. ACI is Advancing Care Information. I is Improving Activities. And I'll be going through a few more acronyms as and when we come across during this presentation. A few highlights about the Quality Payment Program Year 2 that are relevant to reporting for the 2018 performance year, especially with respect to this presentation. The performance year threshold has been increased to 15 points, which is a significant jump from 3 points in the 2017 transition year. This is a very achievable feat, which you will realize by the end of this presentation. The low volume threshold has increased this year. Clinicians who submit more than $90,000 in Medicare Part D claims annually and see more than 200 Medicare beneficiaries annually will be eligible to report for MIPS this year. Also, clinicians will be required to report on cost performance category that will account for 10% of total MIPS score. Clinicians don't have to submit any data for this category. CMS will pull your data from claims. Quality will account for 50% of total MIPS score versus 60% last year, and there is no change in the advancing care information and improvement activity performance category. ACI is 25% and IA is 15%. Here are the data submission options. Currently, there is one submission mechanism for performance category. However, there will be multiple submission options in 2019. So talking about reporting, we would like to remind you that the deadline for data submission for the performance year 2017 is March 31st, 2018. If you're submitting data via the CMS web interface, the submission deadline is March 16, 2018. Before you submit data, we always recommend that you at least check your denominator to ensure the accuracy of the data you're reporting. Most of you should have an idea of how much of your population falls under what category. Example, if you're approximately seeing 100 patients that are diabetic, but your denominator for, say, hemoglobin A1C shows only 10 denominators, then you will know something is wrong with the data. We also recommend that you keep your data and documentation for up to 10 years, since CMS reserves the right to audit even after 10 years you've submitted your data. Next slide. In this section of webinar, we'll be going over a few ways of avoiding a negative payment adjustment and a few ways you can and a few steps you can take in order to prepare for the performance year 2018. So as I had mentioned earlier, the performance threshold has been set to 15 points. For small practices where there are less than 15 eligible clinicians will get 5 points. So essentially, small practices just need 10 points to meet the performance threshold. Larger practices, however, have to earn 15 points to meet the performance threshold. Here are a few ways you can avoid a negative payment penalty. Before I get into these, a quick note for you is that the calculation of the scores are based off the assumption that you will score a minimum possible points if you meet the data completeness requirement. The chances are that you will score more than the bare minimum. The first method listed is for a small practice, meaning where there are less than 15 eligible clinicians in a group practice. The small practice can report on a high-weighted activity, which earns you full 40 points in the improvement activity category and hence 15 points of total MIPS score. Or you can report on 2 medium-weighted activity will also give you 15 points of total MIPS score. Similarly, for a large practice where there are more than 15 eligible clinicians in a group practice, you can report on 4 medium-weighted improvement activities or 2 high-weighted improvement activities, and that will give you 15 points of total MIPS score. The next one is for a large practice where you can report on 6 quality measures and make sure you report on 1 outcome or high priority measures. This will give you 9 points of total MIPS score, assumption being you score least possible points for each measure if you meet the data completeness requirement. And reporting on 2 medium-weighted improvement activity will give you 7.5 points, and that will in turn give you 16.5 points of total MIPS score. If you have a certified EHR, you can report on base advancing care information measures, and that will give you 12.5 points of total MIPS score. And reporting on 2 quality measures will give you 3 points of total MIPS score, and that leads to a total of 15.5 points. Another way of reporting for a large practice will be to report on 3 medium-weighted improvement activity, and that will give you 11.25 points of total MIPS score, and 3 quality measures will give you 4.5 points of total MIPS score, and also 3 medium-weighted activities and 3 quality measures together will give you 15.75 points. The last one listed is for a small practice where you can report on 1 medium-weighted improvement activity, which will give you 7.5 points, and 5 quality measures will give you 7.5 points of total MIPS score, and that leads to a total of 15 points of total MIPS score. This next slide are a few steps you can take in order to prepare for reporting. First thing to do is, before you choose the measure, is to assess your resources, like how many staff members you have. Example, if you have a few nurse practitioners and one physician, how are you going to empanel your patients? Or if you have a certified EHR, you could choose measures where you could utilize your EHR for any bonus points. The next step will be to assess your workflows before you choose your measures. For example, some of the measures require you to administer surveys to a patient, or the patient has to answer some kind of a questionnaire. How and at what point will you accommodate that? Make changes to your workflow if necessary. For example, if you're doing medication reconciliation and certain measure requires you to document that in a little more detail. For example, include dosage, frequency, route of administration, or any herbal meds that the patient is taking. This will require a minor tweak in the workflow, like just adding a few extra fields in your EHR. Make a plan on how to document and how you will store the data in day-to-day operations. If you're using a certified EHR, again, you may just need to add a few additional fields or screens while documenting the information. Or if you're capturing some information from patients like paper survey, you need to make a plan how you eventually store and incorporate it in the patient care. Monitor your progress regularly. If you have a certified EHR, most of them should have a MIPS dashboard that will show your performance on the measures you have selected in each performance category. If you're reporting live claims, you can ask the billing staff to make a note of the measures that are being reported, and then eventually you can assess your data. This next section of presentation will be focusing on how you can group measures that follow certain theme and have similar reporting requirements. Doing this will significantly reduce the burden of making changes to your workflow and therefore in turn making reporting for the quality payment program easy. The first theme of measures we'll be going through is medication management, which is done and is important for most practices, if not all practices. The first one is the improvement activity. It's called implementation of medication management practice improvements. This improvement activity requires a clinician to manage medication to maximize efficiency and safety of medications prescribed or administered to a patient. This will involve a clinician to reconcile and coordinate medication across transitions of care settings. A simple workflow that most clinicians can follow is to reconcile the medication list along with the problem list and allergy list when a patient comes into a particular setting or a facility. Similarly, when a patient is moving out of your care facility, sending out a reconciled medication list into the next setting is the easiest way of working on this improvement activity. Also, you could integrate the pharmacist into your care team and conduct periodic and structured medication reviews, and you can easily report this as improvement activity. The next one is a quality measure. It's called medication reconciliation post-discharge. This quality measure requires the eligible clinician to report percentage of discharges from any inpatient, example, hospital, skilled nursing facility, or rehabilitation facility for patients 18 years and older of age seen within 30 days following discharge. When such a patient is discharged and is seen by a clinician within 30 days of discharge, the clinician will have to reconcile the discharge medication list with the outpatient medication list, which is very much in line with the first improvement activity we just discussed. The next one is also a quality measure. This measure entails reporting percentage of patients aged 18 years and older, where a clinician is documenting a list of current medications using whatever available resources at the time of encounter. This must include all prescriptions, all the over-the-counter herbal, vitamin supplements, and must contain medication, dosage, frequency, and route of administration. So basically, this entails MedRec in much high detail, but can be easily accommodated in the workflow. The last one is called Clinical Information Reconciliation. This is a ACI measure, that's Advancing Care Information Measure, and this isn't a base measure. If you have a certified EHR and are planning to report on basic advancing care information measures and reporting on any of the earlier measures just discussed, you can report on this measure to earn performance points in the ACI category. This is the HIE, that's Health Information Exchange measures, where there is a transition of care or referral or patient encounter in which the eligible clinician has never before encountered the patients. The MIPS eligible clinician will perform clinical information reconciliation. So what the clinician needs to do is just to use his EHR to either reconcile clinical information like medication, medication allergy, and current problem list. Again, which is pretty much in line with whatever the quality measures and improvements discussed. The next set of measures follow the theme of population health management. The first improvement activity is chronic care and preventative care management for empaneled patients. For this measure, the chronic and preventative care for empaneled patients, the clinician must attest for this activity if you provide patients annually with an opportunity for development and or adjustment of an individualized plan of care appropriate to age, health status, gender, etc. If you offer advanced care planning, you can attest for this activity, or if you use condition-specific costing for care of chronic conditions, example, hypertension, diabetes, or depression, you can attest for this improvement activity. Or if you use reminders and outreach, example, phone calls, emails, or patient portals, to alert and educate patients about services that are due and perform routine medication reconciliation. Again, this is very much in line with the first theme of measures we discussed. The next improvement activity is population empanelment. So this is the CMS definition of empanelment. Empanelment is a series of processes that assign each active patient to MIPS eligible clinicians or group and or care team, confirm assignment with patients and clinician, and use the resultant patient panel as a foundation for individual patient and population health management. So for effective empanelment, you will have to identify your active population of the practice, especially those patients who identify your practice as a source of primary care. For effective empanelment, you have to empanel your active population for that complexity. The last improvement activity is a high-weighted improvement activity. If your facility is ECMH recognized, then you can attest for this activity and get full credits in the improvement activities performance category. The next group of measures is particularly important due to the current situation of opioid epidemic. The first improvement activity is annual registration in the PDMP or Prescription Drug Monitoring Program. So what is PDMP? PDMP is basically an electronic database that tracks controlled substance prescription in a state. PDMP is a state-level program, and all of our New England states have an operational PDMP. This requires annual registration by an eligible clinician or a group in the PDMP of the state where they practice. So just simply registering won't suffice. You have to have a documented proof that you've been using PDMP. For example, not just your activation emails, but evidence of participating, like accessing and consulting the database while you are prescribing a controlled substance. The next one is high-weighted improvement activity, and it's called consultation of the Prescription Drug Monitoring Program. Clinicians will have to attest that 60% for the first year or 75% for the second year that they've been using PDMP prior to issuance of controlled substance Schedule 2, commonly known as CS2, opioid prescriptions that last longer than 3 days. The clinician will have to document total number of issuances for CS2 prescriptions that last longer than 3 days over the same time period as those consulted. total number of patients for which there is evidence of consulting PDMP prior to issuing a CS2 prescription. Examples, copies of patient reports created or PHI with the PHI mask. The last one is, second last one is a quality measure. It's called opioid therapy follow-up evaluation. All patients 18 years and older prescribed opiates for longer than 6 weeks duration who had a follow-up evaluation conducted at least every 3 months during opioid therapy documented in a medical record, which is very much in line with the next quality measure, evaluation or interview for risk of opioid misuse. There are several validated instruments like opioid risk tools, SOPAR, for example, and ORT is opioid risk tool, DIRE is diagnosis, interactability, risk, and efficacy score. SOPAR is screener and opioid assessment for patient with pain device. CSAP is screening instrument for substance abuse potential. This will involve a simple workflow of the nurse practitioner handing out the tools mentioned form to the patient. The next group of measure is called beneficiary engagement. The easiest way of achieving or implementing any of the improvement activities is by implementing a PSAC, commonly known as Patient and Family Advisory Council Committee. The first improvement activity is called regularly assess the patient experience of care through surveys, advisory councils, and or other mechanisms. You can conduct periodic PSAC meetings like once a month where you can conduct surveys regarding experience of care. You can document the discussion of the meeting and anything that you've implemented coming out of this meeting. The next one is engagement of patients, family, and caregivers in developing a plan of care. So if you have a certified EHR, document the plan of care you discussed with the patient or the family, and like example, prioritizing the goals of action. If you're seeing a diabetic patient, you can document the nutritional plans, any exercise that was recommended in your EHR. The next one is called engage patients and families to guide improvement in system of care, which is pretty much similar to the earlier one we discussed. Document the plan of care, prioritizing of goals with patients and their families in your certified EHR. The last one is a quality measure. It's care plan. If you see patients aged more than 65 years or older, then you have to report the percentage of patients who have an advanced care plan or surrogate decision maker documented in the medical record. If they decline to have any of the above, you can just report the same and you can attest for this particular quality measure. The next group of measures is called quality improvement. The first one is implementation of formal quality improvement methods, practice changes, or other practice improvement processes. This will involve implementing quality improvement activities in your practices that will include your staff in participating practice improvement processing. Example, reviewing patient care survey together, discussing the data results, implementing changes to workflows in your practice. CMS recommends that you document 6 or more activities when the patient staff is involved in such practice improvement activities. The next one is implementation of methodologies for improvement in longitudinal care management for high-risk patients. This measure involves stratifying your patients based on high-risk status. Based on the risk status identification, base a personalized plan of care for patients. Use on-site, practice-based, or shared care managers to proactively monitor and coordinate care for the highest risk cohort of patients. Example, if you have assigned high-risk status for your diabetic patients or COPD patients, you can document the risk assignment and risk stratifications into actionable risk cohorts and create and document a personalized care plan. And you can use your on-site managers or shared care managers to monitor and coordinate care for that cohort. For example, you can ask them to check if they've been monitoring their blood sugar regularly. The next one is called practice improvements that engage community resources to support patient health goals. So the clinician will have to develop pathways to neighborhood community-based resources to support patient health goals, which could include like a chronic disease self-management support or exercise programs. So basically, the clinician will have to provide a link to available community resources. So the next set of measures will be discussed by my colleague Tushara.
Thank you, Radhika. So now the electronic health record utilization. For QPP Year 2, the ACI category score accounts for 25% of the MIPS composite score. And ECs are required to report on the base measure depending upon their EHR certification year. So we have identified some EHR-related measures that can be grouped together for EC MIPS reporting. First one, engagement of patients through implementation of improvements in patient portal. To meet the requirements of this improvement activity, the practice should not only establish a secure portal, but also incorporate the functionalities like patient interactive features that include bi-directional communication. Using a secure username and a password, patients should be able to view the health information such as recent doctor visits, discharge summaries, medications, lab results, etc. And incorporating the patient engagement features to the portal such as exchange secure messages to clinicians, requests for non-urgent appointments, prescription refills can also be done to meet the requirements of this improvement activity. The documentation for this improvement activity can be through screenshots or reports of an enhanced patient portal. For example, portal functions that provide up-to-date information related to chronic disease, health, or blood pressure control, interactive features allowing patients to enter health information, and bi-directional communication about medication changes and adherence. The next measure is it's a high priority quality measure. It's closing the referral loop, receipt of specialist reports. The patient population for this measure includes number of patients, regardless of age, who were referred by one provider to another provider and who had a visit during the measurement period. In order to satisfactorily meet the measure, ECs need to make sure that the referring provider receives a report from the provider to whom the patient was referred to. Again, the provider to whom the patient was referred to should be the same provider that sends the report. If there are multiple referrals for a patient during the measurement period, use the first referral for documentation. Always follow up with the provider if you haven't received a report from them. Once you receive the report, make sure that it is properly documented. Keep in mind that the goal is to track and support patients when they obtain services outside your practice, reduce fragmentation of care, and to ensure safe and timely referrals or transitions. The next one in the group is implementation of the use of specialist reports back to referring clinician or the group to close referral loop. This is a medium-weighted improvement activity in the care coordination category. It's very similar to the quality measure we discussed just now. In order to meet the requirement of this measure, the practice needs to have an established workflow, including a system to receive and document referrals in the EHR. The documentation of this improvement activity may include sample of specialist reports reported to referring clinician or group, for example, within EHR or medical records, or specialist reports from inquiries in certified EHR. For example, those documented in inquiring clinicians, certified EHR or medical records. And here are some general strategies for referral management to meet the requirements for all the above mentioned measures. 1. Assigning an accountable referral person within the organization. And open referral status report and run chart in a timely manner. You can do it weekly or bi-weekly according to your preference. Then emphasizing shared accountability and specialty-specific and destination-driven referral attachments for proper documentation. And here are some measures from quality and improvement activities categories. A practice can choose to report together if they are focusing on better care transition practices. First one, care transition documentation practice improvement.
In order to meet the requirements of this medium-weighted improvement activity, the practices should implement processes for care transition that include documentation of how a MIPS-eligible clinician or group carried out a patient-centered action plan for the first 30 days following a discharge. For example, how the staff are involved in the process. What are the efforts taken to ensure a smooth transition? For example, any phone calls were made, accompaniment, navigation actions, home visits, patient information access, etc. Should be documented. And other suggested documentation include documented processes for developing regularly the individual care plan for at-risk patients, or patient records demonstrating that the care plan being shared with a beneficiary or caregiver of the patient. Next one is an improvement activity, and this improvement activity goes hand in hand with the one we discussed just now, but has slightly different requirements. The practice needs to establish standard operations to effectively manage the safe transitions of care. It includes establish formalized lines of communication with local settings in which empanels patients receive care. The goal is to ensure proper documentation and avoid fragmented care. The other requirement is to partner with community or hospital-based transitional care services. And the main documentation CMS is looking for is the functionality of information flow during the transitions of care to ensure seamless transition. We have identified a couple of quality measures that are focused on the same area too. One is medication reconciliation post-discharge. My colleague Radhika mentioned about various workflows that can be incorporated into a practice for successful medication reconciliation earlier. So I'm not going through them again. And the next measure we identified in the same group is use of high-risk medication in the elderly. The population identified for this measure are the patients 66 years of age and older, and who were ordered high-risk medication. The measure requires to report on two ways. One, percentage of patients who were ordered at least one high-risk medication, and the percentage of patients who were ordered at least two different high-risk medications. Make sure that you document all the essential information, including indication and diagnosis for the drug. Might have multiple, make sure that you capture all of them. Document the start date if new to a drug. Stop, resume, or change date if applicable. Duration of the therapy if it's shorter. Date, time, strength, route, and laboratory monitoring if applicable. So on the slide, we will be discussing the measures related to the chronic disease management that can be reported to the nurse. The first one is diabetes, hemoglobin A1C poor control. The numerator for this measure are the patients whose most recent HbA1c level performed during the measurement period is greater than 9%. The denominator includes patients 18 to 75 years of age with diabetes if it is during the measurement period. Keep in mind that this is an inverse measure, that is, a lower calculated performance rate for this measure indicates better clinical care or control. This measure is to be reported for a minimum of 1 per reporting period for patients with diabetes during the measurement period. When reporting via claim, make sure that you submit the listed ICD-10 CM diagnosis code, CPT or CPT code, and appropriate CPT category code. The quality data codes listed may not be submitted for registries that utilize registries, but sometimes the registries utilize claims data. And again, there are no allowable performance exclusions for this measure. The next one is an improvement activity. It's glycemic management services. This highlighted improvement activity under the population management category goes hand in hand with the previously mentioned quality measure. To satisfactory report for this improvement activity, the clinicians or practitioners should document diabetic patients prescribed anti-diabetic agents. That is, the total number of outpatients who are diabetic and prescribed anti-diabetic agents, and the number of diabetic outpatients with documented glycemic treatment course.
And the goal is to take into account taking specific factors including at least age, comorbidities, and risk for hypoglycemia, and are flagged for reassessment in the following year. As improvement activity is an attestation-only category, make sure that you document everything in accessible specialty-specific folder in case of an audit. Make sure that the clinical staff knows where and how to document for this measure. Training or education should be provided to the new staff if necessary. Next one is heart failure, angiotensin converting enzyme inhibitor or angiotensin receptor blocker therapy for left ventricular systolic dysfunction. There are two reporting criteria for this measure. One, patients who are 18 years and older with a diagnosis of heart failure with a current or prior LVF less than 40%, seen in an outpatient setting with the two denominator eligible visits, or patients who are 18 years and older with a diagnosis of heart failure with a current or prior LVF less than 40% and discharged from hospital. To satisfy this measure, it must be reported for all heart failure patients at least once during the measurement period if seen in an outpatient setting. If the patient has an eligible inpatient discharge during the measurement period, it is expected to be reported at each hospital discharge. The last one in the group is engagement of QIN-QIO to implement self-management education programs. QIN-QIOs were especially successful in achieving impactful results in areas of care coordination, diabetes care, cardiac health, and nursing home care. For example, QIN-QIOs provide diabetes self-management education, DSME classes, to the beneficiaries in minority, diverse, and impoverished communities. And suggested documentation for this medium-weighted improvement activity includes documentation from a QIN-QIO for eligible clinician or group engagement, and the use of services to assist this. For example, for the DSME classes, make sure that you document meetings, agenda, minutes from discussions, classes conducted, list of attendees, and save in a specific folder. U.S. healthcare and health systems integration aims to ensure that behavioral healthcare services are more accessible and connected to the broader healthcare system. And these are some measures focusing on the behavioral and mental health. One, implementation of co-location PCP and mental health services. The main focus of this improvement activity is to integrate, facilitate, and promote the mental health and substance use disorder services in primary and non-primary care settings. And the documentation to support successful reporting for this improvement activity may include, for example, the list of NPIs that participate as behavioral health specialists, mental health clinicians, or patient claims showing mental health and substance use disorder services co-located in primary and non-primary clinical care settings. The next one is implementation of integrated PCBH model. To meet the measurements of this, the requirements of this measure, practices need to offer integrated behavioral health services to support patients with behavioral health needs, including dementia and poorly controlled chronic conditions. And the workflows that support the successful reporting of this improvement activity are the following. Use evidence-based treatment protocols, evidence-based screening, case-finding strategies to identify individuals at risk and those in need of services. Ensure that regular communication and coordinated workflows happening between eligible clinicians in the primary care and behavioral health, and conduct regular case reviews for at-risk or unstable patients and those who are not responding to treatment. And the related quality measures under this category are preventative care management and screening, screening for clinical depression, and follow-up plans. The suggested documentation and workflows we identified for the successful reporting for this measure include a clinical depression screen that is completed on the basis encounter using an age-appropriate standardized depression screening tool, and, if possible, a follow-up plan should be documented on the date of positive screen. And I just want to be more clear about the screening tool. The name of the depression screening tool utilized must be documented in the medical record, and the depression screening must be reviewed and addressed in the office of the provider citing the code on the date of encounter. And the screening and encounter must occur on the same date. Next one is follow-up after hospitalization for mental illness. In order to meet the requirements, the practices or EPs need to report on the percentage of discharges for which the patient received follow-up within 30 days of discharge, and the percentage of discharges for which the patient received follow-up within 7 days of discharge. And all the documentation mentioned for the previous measure are also applicable to this measure. Specialty care. We have identified and grouped some commonly used measures that spread across different specialties. Please note that this is not an all-inclusive list. One is documentation of current medications in the medical record. We have previously mentioned about it, so I'm not going through it again. Next one is preventative care screening, tobacco use screening, and cessation intervention. This measure is intended to promote others' tobacco screening and tobacco cessation intervention for those who use tobacco products. And the submission criteria for this measure are the percentage of patients aged 18 years and older who have screened for tobacco use one or more times within 24 months, and those who have screened for tobacco use one or more times within 24 months and who received a tobacco cessation intervention if identified as a tobacco user. To be more clear, tobacco cessation intervention includes brief counseling, that is 3 minutes or less, and pharmacotherapy. And for the purpose of this measure, brief counseling both in person and over the phone qualifies for the numerator, and written self-help material, for example, brochures, pamphlets, and complementary or alternative therapies do not qualify for the numerator. Please make sure that you document the phone calls or any other cessation intervention used to meet this measure. Next one is preventative care and screening, the influenza immunization. And this measure is to be submitted a minimum of 1 full visit for patients seen between January and March for 2017 to 2018 influenza season, and a minimum of 1 full visit for patients seen between October and December for the 2018 to 19 influenza season. The last one is care coordination agreements that promote improvements in the patient tracking across settings. The main aim is to track patients, refer to specialists through the entire process, and systematically integrate information from referrals in the plan of care. And the suggested documentation includes care coordination agreements and tracking of patient referrals to the specialist, that is the medical record or EHR documentation, demonstrating tracking of patients, report to specialists through the entire process, and referral information integrated to plan of care, that is like samples of specialist referral information that is systematically integrated into the plan of care. Next one is patient information exchange. The related measures in this category include 1. Practice improvement for bilateral exchange of patient information. And this medium-rated improvement activity comes under the care coordination category and focuses on ensuring the bilateral exchange of health information. And to meet the requirements, the EC should incorporate necessary workflows and document participation in an health information exchange, that is email confirmation, screenshots, or that is demonstrating active engagement, or sample of patient medical records, including structured referral notes. The next one, care transition, standard operational improvement. The main goal of this improvement activity is to establish standard operations to manage transitions of care more effectively. I have already mentioned the suggested documentation and workflow for this measure, so not going through them again. And another one is it's an improvement activity, implementation of documentation, improvement in practice, and process improvement. The goal of this improvement activity is to establish effective documentation protocols and workflows for better care coordination. For example, documented care coordination encounter that tracks clinical staff involved and communication from the date patient is scheduled to the day of procedure. That's a good example for this. And the last one is health information exchange. This is a related API category measure, and to meet the requirements, the MIPS eligible clinician should use certified EHR to create a summary of care record and electronically transmit that summary to a receiving healthcare clinician for at least one transition of care or record. And the suggested workflow includes always cross-check and ensure the ability of your EHR to create a summary of care record. And after the referral is sent, obtain reasonable certainty that receiving clinician has received the referral and attached summary of care. And most EHRs have a receipt checkbox to fill in. And the next one is engaging with QIN-QIO. QIN-QIOs bring Medicare beneficiaries, providers, communities together in data-driven initiatives that increase patient safety and make communities healthier and improve clinical quality. And we have listed some measures from MIPS quality and improvement activity categories, which practices can report on working together with the regional QIN-QIO. So here are some useful resources. Please visit our website, New England QIN-QIO macro, for more resources and updates. The next link takes you to the CMS Quality Payment Program website, where you can find more information regarding the QPP program. You can check your eligibility status using the NPI lookup tool and more. And we have also attached the link for CMS QPP Year 2 Final Rule Executive Summary. Questions? Feel free to type in the questions in the chat, or you can unmute yourself and call it. Okay, everyone, to unmute yourself, press #6 to ask a question over the phone, or you can enter your questions in the chat box. Be sure to send your questions to all participants. We will take as many questions as we can. However, be assured if your question is not addressed during this webinar, we will make sure someone gets back to you to address it. Okay, and Tashir, do you want me to read the questions that have already been asked?
Yeah, sure.
Okay. The questions have been answered, and a couple of them we will address. Okay, so the first question was from Michael. It said, in 2018, can practices with 2 to 4 clinicians report as a group with claims? And that was answered by Leela, and she said that Michael, claims-based reporting is only available for reporting as an individual. And do you ladies have anything to add to that?
So that's perfect. So using the claims, you can report only like individually, and you can't use claims for group reporting.
Okay, and then Michael had a suggestion that the reporting slide should probably be changed. Also, a small practice, 5 points reports on a medium-weighted IA, 7.5 points, and cost 10% is automatically included. Would practices be eligible for negative payment? And
yeah, go ahead.
Okay, no, I'm sorry. I thought there was more to it, and it's a different question.
Okay. Michael, yes, you're right. Small practices will earn 5 points, but we always encourage our practices to go for whatever is possible. So we recommend that you report on 15 points, regardless of you getting 5 points. Also, you are right. Then 10% is automatically included, but again, that is based on your performance. So you may not get the entire 10 points. So we highly encourage you work on getting your workflows aligned to some of the measures you would like to report.
Okay. From Brittany, does CMS plan on adjusting IAs or ACIs in the future? A lot of things don't apply to some specialists, for example, optometry.
Hi, Brittany. Yes, CMS is continually adjusting their improvement activities and ACI. They usually have a few groups, few specialists where they meet and try to adjust according to the feedback they're getting. A lot of things do not apply to some specialists. You are right. But optometrists can report on a lot of medication management, quality measures and improvement activities. And if you go on the QPP website, you should find, you should be able to refine the quality measures for the specialty you want to report on. If you have difficulty in finding that, our contact information is listed on this slide. Please feel free to get in touch with us and we'll help you out with selecting the right quality measure or the improvement activity for your specialist.
Okay, from Lucy, when will we get the slides from today? And Lucy, I just entered in the chat box the location where you can get the slides. The next question is from Michael. We also work with a large number of optometrists, and we are concerned that their common measures, such as the dilated eye exam, are benchmarked and due to dismissal in near future. How is CMS planning on tailoring MIPS to small specialty practices?
Michael, like I answered briefly, there are a few medication management quality measures that are available. If you can get in touch with us, we can definitely help you out with finding the right quality measures for your specialist.
Okay. And that was a question also from Brittany. Also from Michael. You are likely to cover this, but a very large percentage of optometry EHRs are unable to produce QRDA3 files in 2017. So the practices are unable to report on quality measures in 2017.
So Michael, I understand that. Another way of reporting for quality measures is you can enter the data manually. Few registries should be able to help you out with that. You can just type in your numbers, and you should be able to report quality measures.
Okay. From Rachel, does it matter how you get to 15 points? You said you could report on base required measures for ACI and quality measures and get to 15, but what about IA? Do you need something from each category?
Hi, Rachel. That's a very good question. So what I presented is a few permutation combinations of way you can achieve 15 points. You do not have to report on each category. A lot of practices saying we don't have a certified EHR, so what's the point of reporting? Now you can report for just quality and improvement activities category, and you can avoid a negative payment penalty. So you can use any permutation combination to report for the quality payment program. I hope that answers your question. Next one, Alberta.
Okay, from Brittany. The documentation of current medications and tobacco use screening are two of the few measures we can report on as an optometry clinic. But my understanding is that these are going to be phased out or not counted because too many physicians Oops. Sorry, my screen moved. Just bear with me one sec.
It's okay, I can read it. That's fine. I can read it. So,
okay.
Hi Brittany, so this is Tushara. So it's true that there will be a few measures that will be phased out in the coming 4 years. But we are unsure about these two measures if they are going to be phased out. But you will be fine for 2017 and 2018. So go ahead with them. And maybe they will be phased out in the coming years, but it's nothing has been finalized. So hope that answers your question.
Okay, and the next question is from Melissa. We are an optometry office, and a lot of these measures do not apply. How many can we be exempt from?
So as Radhika mentioned earlier, so the optometry practice can always choose a lot of quality measures from the medication management side, and sometimes they can choose the primary care specialty measures. So we always recommend everyone to submit at least the minimum amount of data for the MIPS quality payment program to avoid a penalty, to be on the safer side. So just submit the minimum data and avoid a penalty, but we always encourage everyone to submit maximum data to get the maximum score.
Next one.
Okay, from Sharon. Early in the program, it was mentioned that the submission deadline for using the CMS portal was 3/16/18. Is this correct?
So the 3/16/18 deadline is for the EMS web interface. However, the attestation portal will be available until March 31st.
Okay. And then from Melissa, should we still attest if we know we are going to fail?
So this is Tushara. Hi Melissa, as I mentioned earlier, please don't please don't try not to attest. Always try to submit minimum amount of data. You can even submit data via claims, or just submit the minimum amount of data and avoid a negative payment adjustment. CMS is so flexible this year. So try to submit at least minimum amount of data.
Yeah, like Tushara mentioned, CMS is being very flexible. This is the 2017 transition year. They want maximum participation from practices. You never know, CMS may be very flexible and give you some points for bonus points for small practices in case you are the small practices. So yes, please go ahead and report even if you know you're going to fail.
Okay, from Ashley, if a small practice is having a hard time with patient information exchange, i.e. getting documents from other physicians or unable to send them to some physicians, do you have any recommendations on how that can be improved?
So Ashley, this is Tushar. So I don't know if you are excluded from that measure. CMS has finalized an HIE exclusion. I can send you the details of that after the presentation. So I will send you the measure specification fact sheet too, so you'll be able to go through them and you can find out how you can maximize that measure. So after the presentation, we will be in touch with you.
Okay. Less than 8% of optometrists to be eligible for MIPS in 2018, according to early data. Optometrists do not deal a lot with ongoing medication management, especially in Massachusetts, where they cannot treat glaucoma. How can we change this?
So I think the question is a little unclear. So what you can do is we have listed our contact information. So just contact us. We can schedule a meeting or we can talk offline regarding this. And we are here to help you all. You'll be able to choose the right measure so that you can maximize your payment adjustment for next year.
Okay, and this is the last question for now. Thank you all for a great discussion. I have a few announcements before we end today's call. As a reminder, we are now on social media. Tashira, could you promote the slide, please?
Sure.
Visit us on Facebook, LinkedIn, and YouTube. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you will receive an email tomorrow with a link to the evaluation, as well as a link to the event page of our website. The PowerPoint presentation was in your Day of Details email and is in your chat box and will be posted on the website. Within the next few days, a recording and the transcript of this webinar will also be added. Thanks again for attending and have a great day. Tashira and Rajika, do you want to try to take a few more calls? We've got a couple more minutes.
Oh, yeah, we can take a couple more questions, that's fine.
Okay, so the next question is, in 2017, the practice cannot enter quality data manually, only via EHR, QRDA claims as individual only or via register. I'm sorry, that's registry.
So for quality claims, it's true that claims can be used only when you report as an individual, not for group reporting. And it can be entered via EHR and registry. So it's like 3 different mechanisms, like EHR, claims, and registry.
Okay. If we did a few claims-based reporting and are using a registry, do we still have to report on qpp.cms.gov?
Hi, Melissa. If you have reported via claims, you don't have to report again via the portal, attestation portal. You should be fine. But you can always attest for the improvement activities and ACI category through portal.
All right, that's the end of our questions for today. Radhika and Tashira, would you, there are a couple of questions that are specific. Would you please respond to them after the webinar by email?
Yes, so we will respond to all the remaining questions via email. Again, I'll display our contact information. Please feel free to get in touch with us, email us.
Yep, thank you everyone for joining. So as Radhika said, feel free to contact us. Our contact information is displayed. So we are here to help you. So we'll be able to provide you assistance as well as help you to choose the best and most optimum measures so that you can maximize your payment adjustment for this year and for the future remaining years.
Thank you everyone
for attending the webinar. Goodbye.
The leader has disconnected. The conference will be terminated in 5 minutes.